So again, rare diseases and transplantation. And in transplantation, I think we are seeing, antibody therapies have been there for some time, but we are starting to see now the use of advanced technologies, mostly for diagnostics at this point, but I think in the future for treatment potentially. For example, CRISPR-Cas is one potential thing for rare diseases. But the other one could be, in case of diagnostics, we're relying a lot now on at the experimental level, and maybe now in the near future in diagnostic patient care is these RNA-based tests to diagnose rejection, for example, or inflammation, and also genomics to predict outcome of transplantation. For example, gene polymorphism, the use of gene polymorphism to predict graft outcome either in the recipient or donor DNA. And I have some experience with this myself. In terms of actual gene therapies in transplantation, I would say I don't think that I see anything imminently coming out that I'm aware of. But in rare kidney diseases, genetic-based kidney diseases, of course, the gene therapies have been applied in other non-renal diseases, like a musculoskeletal mitochondrial diseases. But I think, and also in cancer, of course. But in rare diseases, genetic diseases in patients, for example, inherited FSGS, for example, I can see this potentially being applied. Again, I'm not aware of anything ready to come to the market yet. So.
Right. Yeah, and we aren't either. I mean, this is going to be we expect a preclinical kind of discussion. What makes sense. And so, all right. So thanks for the overview.
It would be helpful for me if I don't know if you're able to tell me specific diseases or areas where you're interested in, so so we can focus the conversation a bit, maybe.
Yeah, absolutely, doctor. And we're planning to do that after. Well, we could do it.
Sure.
We could do it before and after. I mean, so the indications of most interest to us are acute kidney injury, diabetic nephropathy, CKD, including minimal bone disorder, fibrosis, Alport syndrome, autosomal dominant polycystic kidney disease, IgA nephropathy, kidney transplant rejection, delayed graft function, lupus nephritis, C3 nephritis, and potentially methylmalonic acidemia.
Okay, pretty broad, but yes, now it makes sense. Okay.
Okay, yeah. So we'll come back to that, but the questions are all sort of targeted at understanding what's the best approach for those different indications, given the different modalities that are available. So maybe we can move over to the technology, right? So we're most interested in AAV, not only, but mostly, right? So delivering something through an AAV. Do you see a role for?
So AAV meaning virus-mediated entry, or is that what you mean?
Yeah, so adeno-associated virus.
Yep.
I've
used that many years ago, but yes, I have some experience with that, but not in humans, but I have used it, yes.
Yeah, I mean, so given that you can deliver a missing gene or potentially microRNA, et cetera, I mean, do you see a role for viral vectors, AAV, in the future management of any of these nephrology indications?
Yes, I think for sure there's potential for use of adenovirus-based vectors. I've always had an issue with adenovirus-based vectors because of the immunology aspect and immunity to it. But I know that the technologies have allowed development of more advanced vectors, meaning virus particles. But that was my major concern. But there are other ways to deliver this. The gene therapy is not just virus-mediated. But certainly I have seen it being applied in the research area broadly, the adeno-based vectors.
Right. So we've seen some of the issues too with adeno-based or adenoviral vectors with in the immune response, and there's been a lot of safety issues. But we're more interested in adeno-associated virus. So more along the lines of recently Novartis acquired a company called Avexis for spinal muscular atrophy, right? So CNS indication. But look, we're more interested in that type of technology. And one of the things we're trying to understand is whether or not these things are able to deliver to the kidney. So with systemic administration, whether or not any AAV serotypes, AAV1 versus 5, etc., have the potential to transduce cells of the kidney in general, and if so, sort of which subcomponents of the kidney can be targeted. So glomerulus versus.
Now, I've not used these vectors in humans, but the kidney is remarkably easy. Kidney epithelial cells specifically are remarkably easily to infect with viruses in general. In fact, there was I think there was in the 90s there was a study done looking at organs. After you clear the virus, where does it hang out? And it turns out that many viruses often persist. This is a science paper in the 90s. Persist in the kidney. And if you look at all the major viruses that have come forward and all the studies, including Ebola, many of them they use kidney epithelial cells to culture these viruses. In order to study them in the laboratory. So they are definitely prone to be infected. Kidney epithelial cells are prone to be infected by viruses, and specifically kidney epithelial cells by adenovirus or adeno-related viruses. So I think kidney epithelial cells can be easily infected, and I have seen, and not my own work, but work of others at meetings where they've effectively been able to deliver adeno-based vectors to the kidney. By systemic or intrarenal administration. So there's something about the kidney epithelial cells, perhaps the exposure of receptors to these viruses, that makes them easy to infect with adeno-based vectors. I don't know if that's what your understanding is as well. So.
Yeah, I mean that's kind of what we're trying to understand. There's not a ton of stuff in the literature. There's some.
Now, some of the diseases you mentioned podocyte-based diseases, right? So if you had to get a vector into the podocytes to treat certain disorders, to be honest, I don't have expertise in podocytes, but I imagine it won't be as easy to get this into podocytes compared to kidney epithelial cells. But they're in some form or another, they are actually epithelial cells, but epithelial cell characteristics. So maybe it works, but I've never tested podocytes to be upfront. And same thing with the endothelial cells. I think you can do it in culture, but I've not seen it done in vivo. So. Just another side, for in vivo, for example, some of my colleagues where I am have tried, delivering for example, siRNA or RNA directly without a vector. Using high osmolar solutions, and it's been very effective. But I think the endothelial compartment will be more easily accessed that way. Anyway, this is an aside. So.
Well, that's where we're headed anyway. So I mean that's of interest too. So siRNA. So you're saying is it IV or systemic administrated?
Yes.
siRNAs could. Which
they use the hydrostatic forces. To be honest, I've never used it myself, but they use high amount of a solution, and it's I can't remember if it's high osmolar or not, but it's driven by hydrostatic forces, and they pump it into the circulation, and it delivers, and it delivers specifically the kidney for whatever reason. I guess 20% of our blood flow goes there, so it does remarkably target the kidney. So this is without a vector. So
Right. So that's good to know. I mean those are also of interest to us. What about so another thing we're trying to understand is different routes of administration to the kidney. Mm-hmm. So for example, we've seen papers where they try to deliver let's say an adeno-associated virus with via the renal artery, via injection to the parenchyma versus, the retrograde injection via the ureter. Can you anticipate advantages or disadvantages of those different routes?
Yeah, I think the clear advantage is localizing the treatment. So for two reasons. One is to improve the effectiveness of delivery, and second is to minimize side effects if there are any. Let's say that you don't want that gene or the